Hello students, my name is Moon and this is He200, the Emergency Medical Technicians course at Queensborough Community College, and today's lecture is Chapter 32. The title says OBGYN, but really, what does an EMT responding to a 911 call need to know about OBGYN? It's emergency labor and delivery. And if the mother does not deliver on scene, pre-hospital, outside of hospital, then what other things can the EMT do to make sure that their patient gets to the hospital as quickly and as safely as possible? So let's get into it. I want to make something clear that pregnancy is not a disease. It's a chapter in medical texts, but it's not a disease. It's the body working as designed. So then why are you there? Well, in case something goes wrong. And that's what this lecture slide is. This first half is explanation of how things happen as long as everything works fine. But then the second half of this lecture is the different way, or the most common ways that there is a complication. And that's why you are there, to do all the right things for the most common complications, and hopefully that's all you will encounter in your career. Many years ago, I was surprised to find that quite a few students in the EMT course and also over at the elective introductory health class that I also teach, that many of the new college students, fresh graduates out of the U.S. high school system, got very little sexual education or none at all. And I'm not really sure what's up with that. It's been a while since I went through the high school system, but apparently quite a few never got any sex ed training. Some of them were because they were homeschooled or went to an alternate kind of school, and I guess the teachers there decided that it was not that important. But that's creating some concern for me, fear about what does this student not know, what kinds of problems does a student not know how to avoid. So anyway, if you're in that camp, you're in that experience that you got very little sex ed or none at all, and you're interested in knowing actually how the body works, then here are a great series of videos. So these are YouTube videos. Crash Course is a very nice YouTube channel, and from the ones I've seen so far, they are high quality. They say the right things. They don't go off into crazy assumptions or conclusions. What I like about these videos, at least, is that it's YouTube quality, so YouTube production level, very entertaining, very approachable, lots of nice graphics and cartoons, and the narrator is brisk and well-spoken. It's not an old guy droning on from a textbook like I do. So the time will fly, and you will enjoy your time watching this video as well as learn all this stuff I think you were supposed to have learned. I wish you had learned from before you left high school. So this is a great introduction into human reproduction. At the biological level, how all of this works and how a new baby is made. And then another couple of videos similarly about specifically into sexual reproduction in humans. So at the cellular level, like the ovum and the sperm and how all of that works. And then if you feel like you would like to know more, if you would like to learn as much about human reproduction up to the level that I thought high school students should, or high school graduates should be at, in order to be better prepared for the biological reality that they will run into as adults, then here is a great series, starting with this first video. 5 parts. There's the first video of the 5, and you can go and catch up to all the stuff that you really should know. The next few slides then are a too long didn't read version, And I'm not going to explain this to you. I'm not going to read it to you because many of you already know this. But here it is, just a quick review so that it's very relevant in the context of the things we're going to talk about today. So here are words that you will run into as a healthcare provider, not just an EMT, but a healthcare provider at any level. These are words that you are really expected to know. So refresh your memory if you've learned this before. Go watch those videos if you don't know what these words mean. Similarly here, you've heard the word estrogen maybe. Maybe you heard progesterone on a drug ad. But again, these are words you really need to know as a healthcare provider, even as an EMT. So please get yourself up to speed at the level that we need you to be in order to get the most out of this class and to properly take care of your patient in a 911 call. And then finally, you need to know the definitions of these terms. When you show up at labor and delivery with your patient, words like gestation will be used a lot. You really know what they're talking about. Perinatal and postpartum you will be used a lot. You really need to know what these mean. Okay, now we're going to go into the slides from the actual textbook. Here is an anatomic review of female reproductive organ, and you need to know every word on this list. So do that thing again that I showed you, where you take a copy of the picture, bring up whatever image editor you would like. Hello. Bring up. What's going on? Any image editor you like. Of course, you know me. I'm all about Microsoft Paint because it's cheap, because it's free, and just go around deleting the labels like you see me do here, and then print this out and then test yourself. Now, if you don't have a printer, if you're trying to save on ink, which is absolutely understandable because printer ink is incredibly expensive, and you don't really have a nice screen computer desktop at home to work with, what you can also do is go to this slide in your textbook and take little sticky notes, those post-it notes, and cover the labels and then test yourself. Similarly here, so the previous slide was a front to back view, so anterior posterior view. This is a right to left view, and again you need to know all these words. In fact, why don't you do that right now? Hit pause on this video, learn those words, and then only after you're able to answer all of those labels without error, then you can click resume. All right, physiologic changes in pregnancy. So remember, physiology is how the body works. Anatomy is how the body is structured. And so yes, the mother has to start doing everything for two. And so the cardiovascular system has to not double, but increase blood volume, which is going to be very important when we talk about trauma and bleeding. Cardiac output for our vital signs and pressure, and also heart rate. She's going to have increased oxygen demand because now she's breathing for two, and so you absolutely are going to hope that your oxygen tank is appropriately filled. She could vomit at any moment on scene, so be ready with that emesis bag. Hormones have their effects on the body, and the ligaments, remember, what are ligaments? If you don't know, pause the video, look it up yourself. The act of looking up is part of studying. Instead of me telling you, then your brain will get that information cheaply and will not value it. But if you look it up yourself, now you worked out for it, and now your brain will value it more. So ligaments are become more elastic as the body changes shape to take the increasing size of the fetus in her, and that will result in looser ligaments, which make her prone to injury. Other things that make her prone to injury or increase the risk of injury is that she has this big weight. It's kind of like a bowling ball hanging in front of her abdomen, and it's throwing off her balance. It's causing back pain, messing up her posture. And then if any pre-existing medical condition was there from before she was pregnant, and now it's going to have their effect on the whole gestational process. Gestational diabetes, it's diabetes the way you learned it in the endocrine lecture, but what happened is this lady had no signs or symptoms or past history of diabetes before, but then when she became pregnant, these signs and symptoms are suddenly there. So the high blood sugar, the need for blood sugar lowering medication, which will then expose her to the risk of hypoglycemia. All of that's there. The polyuria, polydipsia, polyphagia. Although polyphagia, it's a little hard to tell if it's because of the gestational diabetes or is it because she's just eating for two. And then after the pregnancy, postpartum, for a little bit after, suddenly all of these signs and symptoms of diabetes disappears. Why? It's not well known, but the fact is that it does happen to some women, some mothers, not all. It's a thing. Be aware now that how will you know if it's happening to the patient in front of you? Simply, well, there's the P in sample, right? Do you have any past medical history? And if this lady is being properly seen by her OBGYN, then she would have been instructed that she does have gestational diabetes, and so she'll tell you. Hypertension, so the blood volume and blood pressure and heart rate are increasing, which means hypertension. The baby needs it, so that's good for the baby, but not so great for the mom. Fortunately, this phase is only about 9 months long, and then her body can recover after it. So some mothers do have hypertension for the 9 months she is pregnant. So what is hypertension? These are the same numbers as before. You learned this in your vital signs training. So systolic and diastolic, as if it's over this, then it counts as hypertension. If systole is over 160 and diastole is over 110, okay, this is malignant high blood pressure, and then you have to worry about something that's very serious, very scary among pregnant women, and that is eclampsia. This is preeclampsia, and then you have to worry about eclampsia. But we'll talk about that coming up soon. Okay, so I mentioned that the baby is going to feel like a bowling ball hanging in front of her abdomen. If the woman is supine, laying flat on her back, and this view looks like, well, I can tell right now, it is the superior to inferior view. It's the camera is starting at the head, looking down towards the feet. Then what are these two dots here? Well, the red represents the abdominal aorta and the blue represents the inferior vena cava. And they are what's causing supine hypotensive syndrome. Well, the pressure on them. So if the mother is laying flat on her back and the weight of the baby is pressing down, then it's really what's happening. The problem is it's pressing down on the inferior vena cava, and that's causing sudden hypotension. And the story is, it's a picture. The story is that you are transporting this pregnant woman to the emergency room for whatever reason. She could have been in a car accident, or she's actually in labor. But anyway, she's in her third trimester, and suddenly her blood pressure crashes. Why? What happened? And And there was nothing about the story, about the call, the mechanism of injury or nature of illness that would make you suspect that her blood pressure would be abnormal, like she only had a broken leg, or she has nausea. But now suddenly her blood pressure is crashing. So let me bring up my trusty drawing, and then I need then to refer you to what you all should be able to draw by now, or at least list on in word form by now, which is the circulatory system. So what's happening is, remember, this is the inferior vena cava going up to the heart, and then here is the aorta, which then comes down to the abdominal aorta here. And then according to that diagram that we just saw, where we were staring at the transsectional image of the cross-section of the abdomen. Okay, what's happening is the pressure of the baby is interfering with blood flow up the inferior vena cava into the heart. So what? The pressure, isn't the pressure, blood pressure supposed to be generated by the aorta? The problem is that as less blood makes it into the heart, there's less blood in the heart to be pumped out. You can be pumping a regular pump. You can be going crazy at there it is. You can be going crazy at an ordinary pump all you want, but if there's not enough water in the system, then not much water is coming out. So as with less blood going into the heart, there's less blood going out of the heart, and not only down to the abdominal aorta, but also one of its branches, which is now going out to the left arm, where you put the blood pressure cuff. And suddenly the pressure in the left arm is crashing, the systolic is going down, and you're scratching your head, you're wondering what the hell is going on, my patient is crashing. And then you realize, wait a minute, I put this pregnant lady, obviously pregnant lady, flat on her back on the stretcher, and she is suffering supine hypotensive syndrome. So what's the solution? And that's what the lecture is about. You tilt the lady on the left, on her left, and that will relieve pressure of the baby off of the inferior vena cava. Wait a minute, you may say, won't tilting the patient to her left cause increased pressure on the abdominal aorta? Isn't that going to be a problem? Well, it's going to be less of a problem than putting pressure on the vena cava, and the main reason why is remember the arteries, especially the aorta is under pressure. How much pressure? Systolic pressure. So the power of the heart, the power of love, the power of the heart will push through the blood under the baby, and it will make it to the lower half of the body, no problem. But the veins are not under pressure, so that's why you have to relieve pressure off the vein. And that's how you stop. So once you do that, you'll notice that within seconds, the woman's blood pressure comes back to what it was, back to baseline when you saw it before transport. Test question. The test question, this will be on your exams, this will be on the final, this will be on the state written exam, supine hypertensive syndrome. Sometimes they won't even say the word supine hypertensive syndrome. They'll just say woman in third trimester being transported for a broken fingernail, and while you secured her to her stretcher supine, and then during transport, you notice that her systolic blood pressure is now dropped to 80 millimeters mercury. What do you do now? And you look for the answer choice that says tilt her to her left. So, speaking of blood pressure, if the blood pressure is really, really high, very, very high, then there is something called preeclampsia. But if you break this out, then it's actually, think of it as preeclampsia. Preeclampsia, the actual preeclampsia, has some associated signs and symptoms, not only the severe hypertension, but there is headache. No wonder, right? If the blood pressure is very, very high and the pressure is throbbing into her brain, no wonder she's having a very bad headache. If the pressure behind her eyeballs is going off the charts, no wonder she's having trouble seeing. Blurry vision is a problem. Swelling in the hands and feet. Swelling in the hands and feet. Why would preeclampsia, severe hypertension, cause swelling in the hands and feet? Well, many reasons, and there is the standard one. There is the one that you already know about, that the blood is going on its way down to the legs, and there is, of course, blood going out to the arms, and these are under such high pressure that it's squeezing fluid. Oh, I'm already using blue for vena cava, for veins. You know what? Water is not blue, water is clear, but let me do that. And the severe high blood pressure in the arteries is pushing fluids out of the arteries, out of the circulation, into the interstitial space, and that is causing pressure. And then that's not only in the legs but also in the arms. That's one of the causes of swelling. There's another cause of swelling in preeclampsia, has something to do with the proteins in the arteries, but that's beyond the scope at the EMT level. You go to the paramedic program, you'll hear all about it, but not here at the EMT level. So anyway, this is preeclampsia. Severe hypertension is the thing itself, but then there are associated signs and symptoms like headache, blurriness, swelling in hands and feet, and other things. Okay, the word preeclampsia is pre, which means before eclampsia. So what is eclampsia? Eclampsia is seizure. If the swelling in the brain gets too much, then the brain can no longer perform its normal function. The brain's neural pathways become impaired, and the patient goes into seizure. After all, what is a seizure? What is a seizure? Well, imagine, the brain is an interconnection of neurons. Imagine the neurons are wires or circuits in a computer, and so coming out of the TV screen, if the TV screen represents a normal functioning brain, then what's going on in the brain, then a normal functioning brain makes a very nice image. Everything's working fine. But then if the neurons, the wires, start to malfunction, then what you see, instead of a very nice picture, a logical picture, is static. So that's a seizure. This neuron, which is in charge of the left leg, this neuron, which is in charge of the diaphragm, this neuron, which was in charge of the right eyebrow, all of this is just, the information is firing ones and zeros, but without any logical order. So the body is now quivering, and that's a seizure. I said diaphragm not working. I said the brain is not working. This is a life threat. Seizures, no matter what caused the seizure itself is a life threat. You know what to do about seizures. You had the neurology lecture already, but I'm telling you, the purpose of mentioning it here, and you should do it for this person too. If your patient starts seizing, do all the things that we taught you to do when dealing with a seizure. But what I'm saying is that, you know what, instead of waiting for the seizure to happen, I'm going back a slide, why don't you prevent the seizure from happening in the first place? So eclampsia is seizure caused by pregnancy, and or hypertension. Pregnancy-related hypertension causes a seizure, which is eclampsia. So why don't you not let it happen by treating preeclampsia? How do you treat preeclampsia? Keep the patient calm. If you see the blood pressure starting to rise, to creep up, and then gets way too high, call for paramedics. Meanwhile, you look for the signs, which is you ask the patient about visual complaints, you ask them about a headache, you inspect their hands and feet, look for signs of swelling, and then if you see swelling, ask them, are your hands and feet this swollen yesterday, a week ago, a month ago? And if the patient is saying, no, they were okay before and now I don't understand what's causing the swelling, okay, call for paramedics. Because paramedics can give medications that not only bring the blood pressure down, but can also prevent or break the seizure. Bleeding. So the mother has extra blood in her body because she has to provide blood flow for two people, delivering precious oxygen and nutrients and taking away the waste products. And now she has to do it for two. As far as EMTs are concerned, in emergency medical systems, EMTs, we're worried about bleeding outside the body. And how would you know a pregnant lady is having pregnancy-related bleeding, like non-traumatic bleeding? Then will there be blood coming out of her vagina? So how would you know that? Well, ask the patient, right? The patient will know, first of all. The patient will say, I'm bleeding, there's blood coming out of my vagina. And how would she know to tell you? Well, you ask her. This is no time to be squeamish. For those of you who are cringing right now, I'm going to tell you, grow up. We are adults. We are responding to a 911 emergency. Be professional. Learn the things you're supposed to know so you can do the right things you're supposed to do, and assess the patient for vaginal bleeding by asking. And then once the patient says, yes, I am bleeding from there, and she's like nowhere near her due date, maybe she's only in her second trimester, she is only at week 30, she's only at week 32 of normally what's supposed to last a 40-week pregnancy. She may be in her first trimester, so she's only in week 6. Then vaginal bleeding, serious sign, you have to look. Once the patient says she's bleeding from her vagina, now you have to look. Get the patient's consent, get her permission, have the patient lift up on her dress, and then show you. Because you're not really supposed to take a patient's word for it. That's symptoms. Symptoms is when what the patient says. Subjective, you have to be objective. You have to get a sign, which is you visualized it for yourself. Now, that's not the only, an ectopic pregnancy is not the only cause of vaginal bleeding. Maybe she is just having a missed menstrual cycle and now it's back. So she thought she was pregnant, especially in the first trimester. She thought she was pregnant, but all she did was she missed a month. And then later she resumed her normal menstrual period, and now she's having a normal period when she thinks she's supposed to be pregnant, scaring her to death, and she called 911. Another cause, you should absolutely ask about pain and abdominal pain. And in fact, any woman of childbearing age complaining of abdominal pain must be evaluated for an ectopic pregnancy until proven otherwise. How is it proven otherwise? In the emergency room, they do a blood test for pregnancy. Yes, I know there is a urine test, but that's a screening test. It has high false positives. The only purpose of the screening test in urine is to justify calling the doctor and coming in for a proper clinic visit with her OBGYN, where the doctor will take a blood sample and then send it to the lab for a more definitive pregnancy test by blood. Well, they'll do it in the emergency room too, to verify if she really is pregnant or not. What's an ectopic pregnancy? I'm pretty sure it's covered soon. Okay, other causes of bleeding from the vagina. Well, how about, well, it could be a spontaneous abortion, which is also called a miscarriage. So I'll put it in quotes here. The word miscarriage is the general public plain English word. In medicine, it's actually called spontaneous abortion. What the general public calls an abortion is in medicine, in healthcare, called an induced abortion. Induced abortion means it was caused by somebody on purpose. Hopefully that was a competent and properly licensed and certified medical provider acting within their scope of practice, hopefully. But anyway, somebody else caused it. That's induced abortion, and that's what the general public thinks of as abortion. But there are medical reasons why the pregnancy will be terminated, such as there's a genetic malformation, the fetus is not viable, or the mother's medical situation has gotten so disturbed that the mother decided to eject the fetus out of the mother, not the mother's mind, but the mother's body. The mother's body ejected the fetus because it was threatening the life of the mother's body. So this is not a conscious decision. This is something that happens in life. And so that's a spontaneous abortion. So that could cause bleeding. And then there's another, many things can cause bleeding. After all, trauma, right? Car accident, assault, they can cause bleeding too. But now for test purposes, especially in this topic, chapter 32, there are other causes of vaginal bleeding, especially in mid pregnancy, is abruptio and previa. I don't know why this didn't get bolded. Abruptio and previa, and they both involve the placenta. Okay, so here is the pictures of abruptio. Abruptio is on the left, previa is on the right. So with abruptio, the placenta, this gray crescent here, is implanted, is growing on the side of the uterus. Where on the uterus? Anywhere. The placement of the placenta is completely random when the embryo implants on the uterine wall. It could be anywhere, top, bottom, left, right, front, back, anywhere. What happens is usually around the middle of the pregnancy, something happened, and the placenta is supposed to be properly, fully attached to the uterine wall, where blood flow from the mom is making its way through the placenta into the umbilical cord, and that's how the growing baby is nourished. If something terrible happens and the placenta starts to detach away from the uterine wall, then these blood vessels that are supposed to bridge the gap start to get ripped and tear away, and they start to bleed, and this hemorrhage or hematoma is growing. Eventually, the blood finally starts to work its way around the outside of the amniotic sac. What's an amniotic sac? Watch those videos about human reproduction. It dribbles its way down outside the amniotic sac to the opening of the cervix, which is the opening, down the vagina, and then out the vagina. and that's abruptio. Abruptio, if you search for it, if you go abruptio in an etymology, the word abruptio is skipping the AI Wiktionary, etymology online. I don't know. Oxford. Oxford is a ancient, established, world respected dictionary company. And so, where's the etymology? Oh, here. Oh no, it's a paywall? I have to pay to see the answer? Well, forget that. Oh, well, okay, abrupt. There's the different one. Merriam-Webster, suddenly breaking off or away. Webster's dictionary. You know, I feel sorry for you young people that you don't know the joys of reading an actual hard copy dictionary. Anyway, abruptio means suddenly, abruptly breaking away. So what could cause that? Well, medical reasons, genetic reasons, but also trauma. You can imagine how a car accident or fall down the stairs could cause abruptio placenta. Previa, placenta previa, is different in that, remember I said the placenta can attach anywhere along the uterine? Well, what if it attached near the opening of the cervix? Then what's going to happen is everything is growing fine, the pregnancy is progressing on schedule, everybody is happy and excited, but then on the day of labor, as the baby's head tries to progress down the vaginal canal, it comes up against the placenta. The placenta is blocking the way, and that's the word previa. Previa sounds like previous or in front of or before. So the placenta is in front of or before the head of the baby, and as the baby tries to progress, it's ramming up against the placenta, causing damage because the walls of the uterus are contracting and trying to squeeze the baby out. So that causes trauma, that causes bleeding. So it sounds like placenta previa is only on the day of labor. Now she may be having premature labor or post-mature labor, but anyway, on the day of labor, she suddenly has this bleeding from the vagina. That's placenta previa. When does abruptio placenta happen? Well, anytime this happens. So it could be anytime from the initial development of the placenta, which is like early second trimester. Well, no, it actually first trimester. From the first trimester all the way up to the day of labor. So anywhere in that 40-week time span. However, statistically, it tends to happen around second trimester, the middle of pregnancy, more, and then some of it in the third trimester. But anyway, so previa happens on the day of labor. Abruptio happens before the day of labor, usually weeks before. And then with abruptio, there's a story of trauma or a story of medical complications. And what else can cause the placenta to detach away from the uterine wall? Placenta, uterine wall, interface. Let's see what comes up here with images. Who's this? Cleveland Clinic. Okay, this is nice. Who's this? Nature.com. I don't know what this website is. Let's go with Cleveland Clinic. Cleveland Clinic, please don't sue me. This is for educational purposes only. And let's get a closer look at this. So here, let's start with a baby. The placenta is against the uterine wall, and then we zoom in and we get this. So here is the umbilical cord up against the placenta, and then there is an interface between the placenta and the uterine wall, and blood vessels are going back and forth, providing mother's blood transitioning to baby's blood. What if the pressure, the blood pressure, so systole and diastole in the mother's circulation gets so high that it pounds against the placenta? Eventually it results in a detachment. So not immediately, but we'll interface abruptio. Let's see if this gets any better. If we can get a close look at this. Osmosis.com is like a training company, kind of like Khan Academy, so probably proprietary. Never mind that. All right, so the pounding of the mother's extremely high uncontrolled blood pressure is causing the placenta to slowly detach, rip away from the uterine wall. What could cause that? Well, like I said, chronic high blood pressure. Maybe the mother has gestational hypertension or has a lifetime history of hypertension that's uncontrolled, or drugs. So the mother is taking uppers, stimulants that spike her blood pressure and causes abruptio placenta too. Of course, as EMTs, that's not our job to figure out, to decide why this happened. We just have to recognize that it's happening, and that's bleeding from the vagina. So the story is, the blood is coming out of her vagina. It's not supposed to happen. And then the way the question asks is, what do you think is going on? And the answer is, if it's on the day of labor, it's probably placenta previa. Look for that in the answer choice. If it's not the day of labor but several weeks before, then it's probably abruptio. And then especially if the question has a story of trauma, drug abuse, uncontrolled high blood pressure, then this is making it more likely that it's abruptio. What are you supposed to do about it as an EMT? Once there's bleeding from the vagina, that's it, just transport. Immediate emergency transport. Call notification ahead to labor and delivery. You are going up to the L&D. You are going right past the emergency room, down the hallway to the elevator. And so if you don't know where the L&D elevator is, then somebody in the emergency room is supposed to walk with you to show you the elevator. And you go all the way up to L&D and then tell them bleeding from the vagina. So what do you do on the way there? What do you do about the bleed? Just put absorbent gauze in front. Just position absorbent gauze in there. She's probably wearing her underwear, so just position the gauze between her underwear and the opening of the vagina. It's a maxi pad. EMTs, ambulance, BLS ambulance has maxi pads as part of the 800. And so if you don't have maxi pads on scene, like you didn't bring it with you in the tech bag into the patient's apartment, then the next best thing is 5x9s. 5x9 gauze. They look like this. 5" by 9" gauze, very absorbent too. And then finally, if for some reason you don't have 5x9s in your tech bag, you're going to have some explaining to do with your supervisor. But you can always use 4x4 gauze. Your tech bag is supposed to have a few of each different kind of gauze. Okay, some more terms you really need to know now. Last menstrual period, absolutely something they will expect you to ask. They, as in the emergency room, is expecting you to ask. L&D is expecting you to ask, and whoever's reading your PCR for quality assurance purposes, supervisor is expecting you to ask. If you didn't ask, if you did not put it on the PCR narrative, you have some explaining to do. Your supervisor is going to call you in one day and say, I need to talk to you, and you two are going to go over this PCR together. There's going to be some re-education, some in-service training in your future. Last menstrual period, you ask the mother, when was the date of your last menstrual period? And then she'll tell you. Because with the LMP, it's a way to guesstimate what the due date is, which is 9 months later. Gravida, how many times have you been pregnant? And how many live births have you given? Okay, the definition of para has been evolving over the past few years, couple of decades. So para may have a different definition depending on which department you're talking to, but for now it's enough for us to ask how many live births have there been, and vaginal and cesarean count. And then the G and the P together is GP. So you're wheeling your patient into labor and delivery. The mother is screaming bloody murder. She's saying the baby is coming. Oh my God, today's the day. And so the staff jump up and they're going to look at you, and you need to say GP. You have to say the number. So G3 P2 means 3 times pregnant, twice gave birth twice. What's the inconsistency? What's the missing number here? Well, she had an abortion, right? The pregnancy, one of the 3 times she was pregnant, the abortion, it didn't end. I mean, it ended too early, and there was no baby. What if you said G2P3? What happened there? How can somebody be pregnant twice but have 3 kids? Huh? That's a puzzle, right? Why don't you think about it? Other things you should ask the patient. So, are you being taken care of by a doctor? Don't assume that, because some people don't get an OBGYN even though they know they're pregnant. Maybe they can't afford the insurance. Maybe in their culture they don't go to an OBGYN. Their culture, it's tradition for them to go to somebody else. Maybe they didn't know they were pregnant. Teenage pregnancies sometimes have that story where either the girl is in denial or just completely ignorant about how babies are made, and then one day she has abdominal pain, and then the doctor says, well, actually you're pregnant. If they are being seen by a doctor, are any complications expected? Because a competent OBGYN should at least get ultrasounds, right? You've heard of the ultrasound. Take blood tests, and then genetic analysis, so the family knows what to expect and what to prepare for. The reason why you're there, right? They call 911, and so the chief complaint, and then it could be abdominal pain, and so ask about the pain. How do you ask about the pain? OPQRST. Ask if there's bleeding. And now, what is spotting? Spotting is when there's little bits of blood, so it's not a continuous flow. I wonder if it will show up here. Labor spotting blood. I wonder if this will show here. Oh, okay, it does. Spotting. So here is spotting blood. Oh, that's a mucus plug. Sorry, that's not spotting. That's a mucus plug. Little dots of blood appear on the underwear, or on the hair spotting, little dots of blood appear on the underwear or the maxi pad, and so the patient tells you. So you have to ask, did her water break? When? So all of those questions were part of the sample. So you have to ask. Now, where in the sample? You figure it out. Which one of these is consistent, or is the proper time and place? Oh, what happened? Which one of those was the proper time and place to ask questions like this? And on the way to the hospital, it would be a great idea to ask some of these questions. Were any of her previous deliveries by cesarean section? And the big concern with the previous C-section is that it leaves a scar on the uterine wall, which means the next time the woman tries to have a normal vaginal delivery, it may rip that scar open. So the doctors need to know. Have you ever had previous problems in a pregnancy? Does she use drugs or drink alcohol or take any medications? Well, that is the M, of course. So after you ask, are you taking any medications, and then follow it up with, do you take drugs or drink alcohol? And you should ask it when no other family member is there to listen, because this could be a very embarrassing topic. So either that, and then if family members are there to listen in and snoop in, then it may cause the patient to deny or to out and out lie. And you don't want that to happen, right? So what are the chances that this is multiple deliveries, twins, triplets, quadruplets, pentuplets, sextuplets, heptuplets, octuplets, nonuplets? Does your physician expect complications? So all of this, great questions to ask on the way to the hospital. Maybe not these, maybe not on scene. These you definitely want to know. The reason why you want to know is because if this is G0, P0, if this is her first pregnancy, then the chance that there is statistically it's going to take a long time for the baby to come out. But if the mother tells you that she's been pregnant 6 times and she's had 5 babies, so G6P5, the baby could shoot right out any minute, even before you finished setting up. LNP will clue you in on the due date, and you just absolutely have to put that in the PCR. Otherwise, you and your supervisor will have a conversation. Where were we? Okay, if the mother called 911 because her water broke, which means her amniotic sac ruptured, then is this a sign of imminent labor? Actually, no. New York State says the water break is not a sign of imminent labor. The purpose of the amniotic sac, remember, is to provide a shock absorber and insulation for the baby, but some things can cause the water to break several days ahead of when the baby's ready to come out. And I've seen L&D wards discharge a patient home because she was not ready for labor, even though her water had broken. So I don't know what the criteria is, but that's what I've seen. I'm not sure why this is here on this slide, but this is like normal delivery. This is what the baby does as it starts to get ready to leave. Barkston Hicks is the most common actual cause of your 911 call for women in labor. And what's going to happen is you are there at your 89, your standby location, hoping to have, an uneventful day, and then suddenly your partner says the Q word. Remember what the Q word is? And then the radio comes to life, and across your KDT, the screen, woman in labor, which is OB Lab, OBLAB is the code for women in labor. And now you realize, oh my God, you have to go to a pregnancy. First of all, pro tip: this is not the time to call back to the dispatcher and say, I have a flat tire, I have engine problems, you're going to have to send somebody else, because this is the oldest trick in the book. Everybody knows it. We've all been there. And you know what the dispatcher's going to do? They're going to send a supervisor to your unit to verify your story. And if it turns out you are lying, you are in big trouble. Don't lie. Just go. It's usually fine. In fact, the vast majority of the times you actually go to an OB lab call is false labor. Braxton Hicks is the woman's uterine is contracting, and it's not a good feeling. She's not going to like it. It's a cramp. It feels like a cramp. Why is there a red line here? Did I spell it wrong? I left out an S. It's a cramp. It's not pleasant feeling, and especially if this is her first pregnancy, she may panic and call 911 and say, "It's it. This is time. Baby's coming," and the entire family goes into panic mode. But then what happens is you get there and you ask couple simple questions. How often are the contractions apart? And if it's more than 2 minutes apart, it's false labor. It's Braxton Hicks. Don't tell that to the patient. In fact, don't tell that to anybody in the family. Don't say it's false labor, because first of all, that's a diagnosis and you're not allowed to make a diagnosis. And secondly, you may be wrong. It may be a different kind of true labor. So don't say that, but just think it in your mind. This is probably Braxton Hicks false labor, and this is a test question. Anyway, do your job. Properly assess your patient. Properly secure the patient left lateral, and then transport. And you will get to the hospital without incident. Everything will hold together. You go up into L&D, and you tell them etc., etc. Oh, and by the way, her contractions are now 5 minutes apart, and that's going to cause L&D to realize, all right, it's not happening. It's not imminent, happening anytime soon. The word imminent is key. The key word is imminent. So if water break and Braxton Hicks are not signs of imminent labor, what are? Well, I just said it. When the contractions are less than 2 minutes apart, it's imminent. So how would you know? What I do is I would tell the mother, tell me every time a contraction starts and when it ends. And I write that on a scrap piece of paper. So if I see that the timing on that scrap piece of paper is getting shorter and shorter, and then finally drops under 2 minutes, that's it. That's the protocol. I need to prepare for imminent delivery. What else are signs of imminent delivery? Well, if the contractions get longer, that although we weren't given a number to look for, like number of minutes for the length of contractions, but as they get longer and longer, it's a sign. Here's a big one, test question. Move her bowels. So what happens is she feels like she wants to go number 2 in the bathroom. Absolutely do not let her. What's going on is the baby's head is now starting to descend into the vaginal canal, and it's now pressing up against her rectum. The pressure against the vaginal canal is being transferred to the rectum. The rectum feels a stretch. It sends a signal to the mother saying there's poop coming. You need to go to the bathroom. But if you let her go to the bathroom, then she may actually deliver into the toilet. So do not let her go. So what if she poops into your setup? Well, go ahead, let her. They do that. It happens. So anyway, and then finally, examine for crowning. Crowning is when the head of the baby appears, is visible at the opening of the vagina. Labor, crowning. So the head of the baby appears at the opening of the vagina here. So here's a crowning. Looks like there's crowning. Here's some crowning here. So yeah, the babies are born with a full head of hair. Okay, that's test question. Crowning, mover bowels, contractions less than 2 minutes apart. There are 4 stages of labor. What did I just say? 4? Why does your textbook say 3? There's actually 4. 1A, 1B, 2, and 3. So 1A, 1B, 2, and 3. Now that your textbook is saying there are only 3, then there is no test question asking you if there are 4 or 3 stages. But no matter who you learned this from, at least you know that second stage is the baby delivering, and the third stage is the placenta delivering. So those two, the last two, are always the same. 1A is when the baby's head is rotating. 1A is when the cervix dilates to 10 centimeters. 1B is when the baby's head starts the rotation, but you're not going to be tested on that. Now that I said it, I'm starting to have doubts. Labor stages 1A, 1B. 1A. Oh, sorry, I was wrong. 1A is when the cervix begins dilating, and then 1B is when the cervix finishes dilating to the full 10 centimeters. This is why I'm not an OBGYN doctor. Oh, there's another reason why the patient may not have seen a doctor about the pregnancy. Not in New York, but in another state. It's that there's no OBGYN doctor available in the entire state. What's happening is in some states in this country, the malpractice insurance is so high, and the jury award for pregnancy complications is so high that every OBGYN doctor fled the state, and nobody will start a practice there. So what do women do if they are pregnant in that state of the country? They have to go get treated in another state. So that's anyway. Okay, so here are back to slide 28. Here are the signs of imminent. Here are the signs of imminent labor, which means that the baby's head is starting to descend. So see how the baby's head is squeezing against the rectum, and so that's why the mother feels the need to push. The top of the baby's head is now visible at the vagina, so that's crowning. Contractions is the uterus is squeezing the baby out, so those are the contractions, all signs of imminent labor. What you need to do then is stop transporting and prepare for delivery. Do not hold the mom's legs together. Don't tell her, keep it together, we'll be in the hospital soon. No, you stop and prepare for delivery. How do you do that? Well, you get your OB kit out. And we have OB kits, and on Saturday you will practice looking through the OB kit. You will practice with our mannequins. We have special OB delivery mannequins, and you will practice delivering plastic or rubber babies. What if you're off duty, like you're there for a friend or family member, and they know you are an EMT and they ask you to help, then at the very least you should have these things ready. So review this if you know friend or family who is getting close to their due date and they have asked you to be present as a favor, then remember this slide. Okay. Position the mother for delivery. So yes, I know there are many different theories or styles or traditions of like how to position the mother in an alternate way, but this is our protocol. New York State protocol says prepare the mother this way. There are, if you go on YouTube or just search on the internet, they have mothers in other kinds of positions. They have them in a swimming pool, other things. They have them sitting in a chair. That we don't do that in New York State EMS. We do it this way. Where are you going to get these sheets? The sheet they're in the OB kit. It's these. So there will be drapes. They're called drapes, and place it over each leg, thigh, and the abdomen. So why do we do that? Well, for modesty, really. And you may think, how can you worry about modesty when she has her knees up and open in front of a total stranger? Well, that part is nothing anybody can do about, but there is something you can do about the other parts of the body. So protect your patient's modesty and privacy. Dignity, especially when other family members are there observing, and maybe according to their culture they have a right to. So she's not allowed to like refuse their presence. But at the very least, then you can cover her up with the things that don't need to be exposed in order for you to do your job. So here is a proper position for mother. She's actually not supine. She's propped up with pillows. If you can do that, great. But knees up and apart, that's really what's important. So preserve the patient's privacy. Use blankets, sheets, and towels to provide support. Don't worry about the inches, just position of comfort. And so, right, okay. Somebody needs to be in front of the birth canal. One of you needs to be at the head, and the one at the head is coaching, providing oxygen if needed. The one who's actually going to catch the baby is observing for crowning. Precipitous is rapid. So especially if the mother has had multiple vaginal deliveries in the past, the baby will come out faster. The perineal area is coming up. Peri means around. So the perineal area is that area of flesh between the reproductive organs and the anus. So men have it too, the perineum. And that's very, very relevant, coming up soon. Okay, so preparing for imminent delivery, you time the contractions for imminent birth. Coach the patient for quick, short breaths. She can breathe deeply between contractions, and then get ready to catch the head as it comes out. Support the head as it rotates. Let me move this up front. So this will define the perineum. Okay, the reason why you want to put pressure, it says with one hand keep pressure on the perineum, so this area between the vagina and the anus, that's the perineum here. The reason why is sometimes the vaginal opening does not expand fast enough for the size of the head. It's supposed to, but sometimes it doesn't. It gets stretched, the size of a baby's head is coming through, and sometimes then it causes a tear. So now, if the tear happens in any other direction, well, the doctors can fix that. Suture and then some wound care, and then after a while it's like good as new. But the one direction it should not go, the one direction it should not go is towards the anus. Because if it does, then what happens is in the like sometime later, every time mom does a number 2, some of that fecal matter goes through the wound, infects the wound, may even go into the vagina, infect the vagina. And that causes not only local infection, but it can cause sepsis, and it can sometimes the bacteria can make it all the way up into the cervix, into the uterus, causing serious reproductive infection. It may even end up causing sterility. And also the presence of the fecal bacteria interferes with wound care so much that it may be permanent. It may cause permanent deformities, interferes with the sexual activity, all kinds of things, reduces quality of life, all because on that one day, that fateful day, the tear went in this direction. So the reason why you put, whoever is catching the baby puts a gloved hand right here on the perineum is to provide support so that if a tear or rip happens, it will happen anywhere else. And then you prevent all of this. Okay. When the baby's head comes out, it tends to be face down more times than not, statistics. So expect the baby to be face down. And see here, the EMT's hand is putting pressure on the perineum. Although if I were the person who drew this, I will put the fingers like actually on the perineum. It looks like they're putting their fingers posterior to the rectal opening, the anus, which is not accurate. Anyway, one hand is putting pressure on the perineum, will also be like the down hand to catch the head, and then there's another hand anywhere else to support the head, and there's not, the other hand now has another important job. Remember the word precipitous birth? What if the baby just shoots out like rocket propelled out of, because the contraction of the uterus is so powerful and the delivery happens so well that the baby just zoom right out? This hand will be great for catching the head, catching the baby, so you don't lose control, you don't accidentally drop the baby onto the surface. Because like I said before, maybe the mother did do a number 2 and there is a little pile of feces right here. It happens. So don't shame the mother, don't make a face, just be professional, be an adult, be professional. Okay, so catch the head as it comes out. Here's crowding. Here's the pressure on the perineum. I'm not sure why this person put their thumb in there, but maybe this is not an EMT, this is a L&D nurse, and she knows what she's doing, or he knows what he's doing, or maybe it's the L&D doctor themselves. Unruptured amniotic sac. So sometimes the water does break, sometimes the water doesn't break. If you see an unruptured amniotic sac, how do you know that? It's unruptured amniotic sac. It looks like a sheet of plastic is around the baby's head. It's okay, we're adults here. Let me turn safe search off. That looks fake. Oh, that's a different kind of rupture. Okay, unruptured amniotic sac. So it looks like there's a sheet of plastic around the baby's head as it's coming out. So it's quite simple actually. You just it's very fragile. It's not tough. You just poke at it. You can puncture it easily. But that means that guess who's right here? Guess who is right here as the water gushes out? You are. You are right here. Maybe your face is right here. So be aware that could happen, which means that as part of PPE for labor and delivery is not just goggles, but one of these beauties. Do you think this is a good idea to wear one of these when your face is right here and the amniotic fluid comes spurting out? I think it's a good idea. And in fact, it's not here, but one of these, it's kind of hard to tell. I think it's this one. One of these is an apron. It's just a plastic apron. And it's just this. I strongly encourage you to put it on, just in case. Okay, the baby's head eventually will rotate. It usually starts out face down, but if by the time the shoulders clear, the baby's head will have rotated up, and now is a great time to clear the baby of the amniotic fluid from the mouth. So use the suction bulb. What suction bulb? This suction bulb here. And the textbook says mouth and nose, but actually I believe your New York State protocol says just suction the mouth. New York State EMS protocol. Download it, and then labor page 71. We'll get to the breathing. Suction. Oh. So clear the infant's airway, suction the mouth and nose. Okay, never mind. So both with the suction bulb, and they will show you how to use the suction bulb, because I can't really show you, I can't really talk about it. It's better and easier to just show you. Okay. All right, so the amniotic fluid, the purpose is multiple purposes. It's a shock absorber, it's an insulator, temperature insulator, and also it keeps everything contained. What's happening is throughout its development, the skin, the baby's skin will slough off naturally, as skin does, and these skin flakes will continue to float in the fluid. But then as the baby starts to have functioning mouth, pharynx, and lungs, it will practice breathing. It'll go through the motions of breathing and also swallowing, and it will do that with the amniotic fluid. So actually the skin cells, which are now floating in the amniotic fluid, will go into the mouth, go into the stomach, work its way through the digestive system, and accumulate in the baby's rectum as baby's first poop. But anyway, that's amniotic fluid. It's supposed to break just before labor, but like I said, sometimes it breaks a few days early. So here is the same picture as I showed you before. Here it is. So once the baby's head clears, then and the baby is the head is starting to rotate, then suction the mouth, because you never know when baby takes their first breath, and you want to get air into the baby's lungs as soon as possible. So get that fluid out of the mouth, and then continue to receive the baby as the baby should naturally, spontaneously flow out. I really like this diagram here, this drawing, because it shows how this bone, do you know which bone this is? Does anybody know the name of this bone? Because back in the skeletal system, I told you need to know it. So you see how it's squeezing down on the passage of the baby, and you see that this is a good story. The shoulder has cleared. Let me go back. Shoulder still down. See, shoulder still down. So good story. Shoulder has cleared. Sometimes the shoulder has a trouble clearing from under this bone. Name of this bone starts with the letter P, and that could be an issue. But fortunately, everything's going fine, and now the baby is almost completely out. Don't drop the baby, okay? Don't drop the baby, and the mouth is already cleared. And then the umbilical cord should follow soon. Once the head is born, you know what? I'm going to say once the shoulder is born, the rest of the body slips right out. Because although the head is the largest cross-sectional area, the shoulders are the longest distance of the baby's body. What do I mean by that? Even though the head is the largest cross-sectional area, the shoulders is the longest distance. Which means, yeah, maybe the head cleared the baby, no problemo. Let me do it this way. Yeah, maybe the baby's head cleared through the vaginal canal, no problemo. But the shoulders may not, because it's just too long and gets stuck behind that bone. Let me just put this in the slide for future reference, for future purposes. Okay. Right. Okay. Save. Why is this here twice? All right. At this point, we are now into stage 3 of labor. At this point, the placenta will start to detach from the uterus naturally, and then bleeding will start. And a little bit of blood is okay. A little bit of blood is okay, about 200 milliliters. One way because after all, the placenta is detached, right? So those blood vessels are breaking. One way to help reduce the bleeding is to massage the fundus of the uterus. Test question. Massage the fundus of the uterus. How do you massage the fundus? Like this healthcare provider is doing. Massage the fundus. What does a fundus mean? Fundus means top. wait a minute. If the fundus means top, then why is she massaging the anterior side of the abdomen? Shouldn't the fundus be here? The reason why the fundus is pointed anteriorly is because the fundus, the uterus leans forward, so that the top of the uterus, the fundus, is pointing to the front of the body, anterior. So by massaging the abdomen, you're massaging. So what happens? Massaging the uterus causes it to shrink back to its original shape sooner. And by shrinking, it pinches off those broken blood vessels, so it reduces bleeding. There's another way to make the uterus shrink faster, which is get the baby to start suckling on the mother's breast sooner. As soon as the baby does that, the suckling of the breast releases a hormone called oxytocin. And oxytocin has two functions. Oxytocin you may have heard of as the hormone of love. It stimulates feelings of love and closeness in the person, but it also stimulates three things. It does that. It stimulates contraction of the mammary glands, so she starts releasing milk for the baby. And the third thing is it stimulates contraction, shrinking of the uterus back to its normal original shape. Now you have a second patient, right? You started off with one patient and now you have two. So how do you take care of this second patient? Post-delivery. Yeah, like it's a little late to be preparing the woman for delivery, right? It's happened. So it's preparing the woman for post-delivery. So it's better to get the baby onto the mother as soon as possible. Skin to skin is also stimulating some of that oxytocin too. Dry off the newborn so that so the baby doesn't lose too much heat through evaporation. Yeah, you haven't had the environmental lecture yet. One of the ways people lose heat is through evaporation, and the baby's all wet from amniotic fluid, right? So dry off the baby and then wrap in a blanket or towel, and then clamp, cut. Clamp the umbilical cord and then cut it, and then get a 1 minute APGAR score. We'll talk about the APGAR score soon. So clamp, cut. Okay, the way I've learned it is 8 to 10 inches from the baby. So I don't know why they put 7 here in the picture. I didn't draw this. It's 8 to 10 inches from the baby plus another 3, which means the second clamp is 12 to 13. 11 to 13 inches. 11 to 13 inches further total. So one clamp at 8 to 10, another clamp 3 inches past that, and don't get out your ruler and measure it exactly, just approximate it, and then you can cut in between. The current OB kits have a special tool. It's not just a scissor, but some of the older kits may have a sterile scissor, and then some of the older kits would have an actual scalpel. The problem with scalpels is that there are like two patients like right next to each other, and here you are swinging your scalpel, so that's kind of dangerous. So scissors are safer, and then a special umbilical cutter is the best. I forgot what it's called. Umbilical cutter. Here, This is what I've seen in OB kits. They look like scissors, but they're designed to do only one thing: cut the umbilical cord. Stage 3, the placenta will eventually deliver around 10 to 30 minutes later. And so remember when I said once delivery is imminent, you stop transport, and wherever you are, you prepare for delivery. Well, at the end of stage 2, when the baby is delivered, you resume transport. You don't wait for the placenta to start transporting. Right? The placenta is just a placenta. It's no longer needed, but the hospital needs to see it for evaluation. They're going to do some tests on it. It's a great source of stem cells, if you've ever heard of that. So that tell the family the ER must examine the placenta. Let's say you delivered in the living room or the bedroom, and now you're transporting. What if the family asks you to give them the placenta for cultural reasons? Tell them you have to take it to the hospital. After the hospital is done, you can request that the hospital gives it back to the family. The placenta needs to be put in a clear plastic bag. Do not put it in a red bag, right? Because anything in a red bag in the emergency room gets thrown away into the biohazard containers. So all clear bag so people can see what it is. Where are you supposed to get a clear bag? Here. Clear bag. That's why it's here. It's for the placenta. Normally the baby will start breathing within 30 seconds after birth, and at no time should their heart rate be under 100 beats per minute. Remember the CPR lecture, the CPR days? So for infants, or this one is a neonate, heartbeat should never fall under 100 beats per minute. If it's between 100 and 60 beats per minute, you provide BVM with oxygen. If it's under 60, you start compressions. CPR, neonate CPR. In order to make them start breathing sooner rather than later, you stimulate them. As far as this baby is concerned, this is the worst day of their life. They were in a warm, moist, dark, supportive environment. The sound of the mother's heartbeat ticking away, everything is good with the world. And then the next thing they know, they're squeezed through a tight muscular opening, a tube, and now they're exposed to bright lights, dry air, loud sounds. Horrible, horrible day, worst day of their life. They should start crying. If they don't, start stimulating the baby so that it is stimulated, it's irritated until it finally starts complaining and it cries. Never, never slap the baby. That's an ancient myth. Nobody does that anymore. Do not hit the baby in any way. Just stimulate it, rub it briskly. So if the pulse is under 100 but above 60, then BVM, one breath every 2 seconds. So squeeze, release, squeeze, release, squeeze, release. CPR for a neonate is now new. I don't think you learned this in CPR. The CPR class, although in the beginning of the semester, was only for infants, which is between, you were told infant was 0 to 12 months. I am now changing it. You are now advanced enough. You are an advanced beginner. You are now advanced enough to learn a detail, which is actually infants are from 1 month to 12 months. Neonate is from 0 to 1 month. A neonate CPR is 3 to 1. That's the ratio. 1, 2, 3, breathe. 1, 2, 3, breathe. 1, 2, 3. Actually, it's 1, 2, 3, breathe. 1, 2, 3, breathe. 2 people. Clearly, this is not the ratio for a single rescue. When neonates need CPR, it has to be 2 people, because the transition time to go from compression to breaths, by that time you've already missed an entire cycle. So instead, it's 2 rescuers going 1, 2, 3, breathe, 1, 2, 3, breathe. 2 rescuers. This is not aluminum foil. This is a mylar cover. It's very soft and a very reflective infrared radiation. You may have seen this in like wilderness survival kits. Mylar blanket. You may have seen this in like wilderness survival kits, and it does a great job of reflecting heat back into the baby. The baby should also be wearing a hat, a baby hat, but it's not in the OB kit. So hopefully the parents have one prepared. Like that. And hopefully the parents have their own ready. If not, cover the head with the towel or the blanket that was also covering. Monitor airway, breathing, circulation, including pulse, and get the APGAR score. And here we are now with the APGAR score. You have to memorize this. You cannot, yes, it's listed on the PCR, but you do not want to waste time looking it up on the laptop, because you need to calculate it at the 1 minute mark, and then you need another one at the 8 minute mark. And the problem with the 5 minute mark, the problem with the 5 minute mark is that you are still very, very busy. You don't have time to look this up, even 5 minutes after delivery. You definitely do not have time to look this up 1 minute after delivery. So you must memorize the APGAR score, and here it is. I won't waste time reading this to you. You're not a third grader, you're an adult, you can read this for yourself, but this is the APGAR score. So 10 best store, since 2 is the best for 5 categories, and 2 times 5 is 10, and 10 is the best. But don't panic if at 1 minute the baby is not at 10. If the baby is at 8 at 1 minute, it's okay. After all, this is the worst day of their life. They just got squeezed through a tight muscular tunnel. The head got smushed. Ever seen a neonate head? The head got smushed, so the brain is not, doing so great. The brain got a little perturbed, a little pushed around, shoved around. So no wonder the APGAR is like 8, which means that it may be a 1 in a couple of these categories here. It should never be 0. If it's 0 for any one of these categories, you must intervene, airway, breathing, circulation issue. But it's okay if a couple of them are just a 1 and the rest are 2s. But then after 5 minutes, it should be a full 10. If it's not, then get to the bottom of it, figure out what went wrong. Don't wait until the baby is born to request a second unit. Once there's imminent birth, it's not a bad idea to ask dispatcher, as you are setting up for imminent birth, ask the dispatcher, this is imminent birth, send a second unit. And chances are they'll probably send a paramedic unit just in case. Oh, when the paramedics arrive, I guess your first thought would be, oh, thank God, paramedics are here. Now I don't have to do this. I don't have to catch the baby. But you know what the paramedics will do? They're going to walk right past you, telling you, good job, EMT, keep up the good work, and they go straight to the mother's head, and they will take care of airway, breathing, circulation. They will set up an IV in her arm. They will not join you down at her legs to catch the baby, because this labor and delivery is an EMT skill. Over at the paramedic program, we don't teach anything new in terms of catching a baby, of labor. We just review what the EMTs are supposed to know at the EMT level. There are some things that the paramedics learn to treat, like preeclampsia and hypotension. These are all airway, breathing, circulation issues. That's what the medics will take care of, and they will use their seniority and their senior medical authorities rank to tell you, the EMT, to stay down there and catch the baby. After all, they don't want their shirt to get soaked with amniotic fluid. They want your shirt to get soaked with amniotic fluid. Right, childbirth complications. So everything up to this point is assuming that everything went fine. The way humans have been doing it for 1,000,000 years, everything went fine. But now, here are the most common things that could go wrong and what you can do as an EMT around it. Blood loss. Okay, so test question. More than 500 milliliters, bad. By half a liter, 500 milliliters is 1/2 of a full liter, so it's about this size. So the kind that you can now buy at the vending machine. You used to be able to buy soda cans, not anymore. Now you have to only the large and the half liters are available at the vending machine. If the mother loses this much blood, now it's bad. The pregnant lady, now it's a serious bleeding issue. Okay, nuchal cord. Okay, as the baby's head appears, you see this thing wrapped around its neck, and that's called nuchal cord. Let's see if there is. Here's a sonogram of a nuchal cord. Here's a better artist depiction. I just want to see if anybody, like an in-action view of nuchal cord. Here. So you see this thing wrapped around the neck as it's appearing out of the vagina. It's the umbilical cord wrapped on the right. So what do? Two things. Two attempts. First attempt, you try to pull out the cord and then slip it over the baby's head, so it's no longer tying up the baby and keeping the baby inside the mom. If that is not happening, if it's too tight and you cannot loose it over the head, clamp, clamp, cut. Clamp anywhere you can get those clamps on. So try to get it about 1 inch apart, but these are tight spaces you're dealing with here. So in a perfect world, you can get the two clamps wide enough apart, but it's hard to know. I mean, it's a perfect world, right? In the real world, you just get them as wide apart as you can, clamp, and then you cut, and then so that at least this releases and the baby's body can now successfully leave the mom. Okay. Instead of a head, you see this thing appearing at the opening of the vagina. If it's not distinct, if it's not hair, if it doesn't look like anything baby-ish, it could be an inverted uterus. What do you do with this? Treat it like an evisceration. Actually, no, not exactly the same. So take saline moistened gauze, cover this whole thing up, secure with a bandage, and rapid transport. Prepare for possible shock, because something is bleeding. So she may have serious internal bleeding. Prepare for shock. This is uterine inversion. If anything other than the head appears at the opening of the vagina, it's called a breech. This is limb breech, and there's no way the baby's coming out the vagina now. The position is all wrong. The baby is just going to get stuck. So what do? You rapid transport. wherever you are. Now get the mother onto the stretcher, and then rapid transport. On the way to the hospital, after you are in the ambulance, you try to raise the buttocks, so raise the hips of the mom, get oxygen on the mom, NRB, non-rebreather mask on the mom, and notification ahead, and rapid transport. I'll talk about meconium later. So elevate the mother's hip, transport, emergency room notification, O2 to the mother. There's no way the baby is being born vaginally this time. This has to be cesarean section. C-section. And that is an arm or a leg. I'll never try to push it back in. Never try to rotate the baby in the body like you've seen it on TV and movies. You are not a doctor. You are not trained. You don't know how to deal with it. Cover with a sterile towel just to reduce the risk of infection. But oxygen to the mother, and then transport. Okay, what if it's a full body breach? As in, like, the entire body is out except for the head. Because remember what I drew here? The head, maybe the shoulders cleared the vaginal canal, but the head is still stuck inside because the head is the largest cross-sectional area. So the head is still stuck inside. What can you do? Well, this is the one of the 2 times an EMT is allowed to insert their fingers into the vagina. The other one is coming up. What you do is you position an oxygen tube in your hand like this, and then you slide these 2 fingers in and separate the face, create a gap, create an air gap to separate the face away from the wall of the vagina. What's happening is the rest of the body is now exposed to the elements. It's irritating. Worst day of the baby's life. The baby is going to start breathing. It stimulates baby's breathing. But if the wall of the vagina is smushed up against the baby's head, the baby will suffocate. So you can get oxygen into the baby by creating this space with your fingers. New York State says swing the baby if this is happening. So what is this swing the baby I'm speaking of? Let's go back to, I already left the protocol. Can I just backspace to the protocol? Or is that not really an option? Hey, breach. And then they said swing the baby. Here it is, swing the baby. Okay, support the buttocks or extremities until the back appears. Grasp the baby's iliac wings. What are the iliac wings? The crest. Here's the pelvis. This is the ilium. The iliac wings are the iliac crest here. Oh, wait, what's this? Yeah, it's the crest. So you hold the baby at their hips, basically what they're saying. Do not pull on the legs or the back, but instead, after you've grabbed the baby's hips, gentle downward traction. So downward is what direction? Downward is this direction. Not towards you, like inferior to the patient's body, but gravity down. Gravity down. And the idea is you're trying to wiggle the head free of this bone. And also the tightness of the vaginal opening. So there. And then, what did they say next? Gently swing the infant's body in the direction of least resistance. So which direction is least resistance? Well, you're going to have to figure this out for yourself. And then anterior and posterior, so front to back, hopefully the shoulders will clear and the head will clear. Splint the humerus bones. So where are the humerus bones? I'm not going to tell you. Where are the humerus bones? Splint is not the orange padded splints. They're not talking about this kind of splint. When they say splint, they mean hold it with your hands. So splinting with your arms, with your hands, the baby's humerus bones, and then gentle traction downward again until the head wiggles free. Anterior, posterior, down and up, and then finally you can swing the body vertical. I will show this to you in class. I will take the time in class to show this to you when we next meet again. So that is what New York State says about, that is their protocol. Okay. Prolapsed umbilical cord. Let's keep the protocol up. Prolapsed umbilical cord. What will you see on a prolapsed umbilical cord? Well, you'll see the umbilical cord sticking out. Let's see here. But I was hoping for like a real life view. Well, baby's already out. Why do they show that picture? Huh. No, in a real life view of a prolapsed cord. I guess, well, prolapsed cord catches everybody by surprise. It's not something you can predict on an ultrasound sonogram. And then I guess in actual labor and delivery, everybody's too busy dealing with it to pause and take a picture. Oh well. So the umbilical cord is what comes out first. The problem now is that as the mother continues to push on the baby's head will squeeze on the umbilical cord, cut off blood supply to the baby for vital time. Sometimes, very rarely, the baby comes right out. But if you've ever seen a real life delivery, it could take a long time. It could take half an hour. I've seen a couple that takes like 2 hours. And so if the umbilical cord is prolapsed and the baby's head is pinching the umbilical cord closed, no blood is flowing into the baby for that entire time. That is unacceptable. This is going to cause baby death. So that's it. The trial of vaginal labor is now failed. You must go to the hospital. This must be cesarean section. So I said there are only 2 times you're allowed to put your fingers in a woman's vagina as an EMT. The previous one was full body breech, and this is the other one. What you do is you put your fingers in, gloved fingers of course, and then you put pressure on the baby's cranium, not the fontanelles though, and you just hold it there. And there you're stuck. For full body breech, you're stuck. For prolapse cord, you're stuck. You just put your hand there, your fingers there, and that's it. All the way up to labor and delivery. It's not just up to the emergency room. Like even when you get there, and hopefully your partner has called notification ahead. When you park into the ambulance parking lot, the emergency room staff will come out, evaluate the situation, and do you think they're going to say, "Good job, EMT, we'll take over from here"? Of course not. They're going to say, stay where you are. Keep doing what you're doing. You're going to straddle that stretcher, and the crew together will get the stretcher out of the ambulance, and you're going to ride that stretcher all the way down the hallway, up the elevator into labor and delivery, with your hand always there. Why doesn't some other staff person take over? Why would they? Why would they want to do that? You are stuck in there. They have other things to do. So they're going to say, good job, EMT. Keep up the good work. That's it. You are now part of the scene, and you are going to be there until they finally remove the baby through cesarean section. You're going to be there during the cesarean section with your fingers in there until the danger is over. Failure to progress is the baby's head cleared but nothing else is coming. And there are a lot of reasons why. The most common reason is the shoulder is now stuck behind the pubic bone. Okay, I was going to make you look it up yourself, but here finally is the answer. The name of that bone is the pubic bone, starts with a P. The shoulder is stuck behind. Now, the OBGYN doctor has multiple different kinds of maneuvers they can do to try to clear the shoulder under the bone. But all you're told, the only thing you're told as a New York State EMT is to guide the head down. That's it. That's all you're allowed to do. Do not pull the head. I need to put this bold and red. Do not pull the head, because you're going to rip these nerve bundles away from the shoulder. That's called shoulder dystocia. So don't do that. But guide the head down. Hopefully the shoulder will slip under. Multiple births. That's what the tape is for in that OB kit. You will have other OB kits will have labeling equipment, and so what you do is you label the first baby, baby A, and use the mother's last name to help identify the baby in case they get separated. And then the second baby is baby B. So A as in Adam, B as in boy. Or I should say B as in Baker. I don't. So anyway, you need to make it clear who was born first. Now medically, it does not matter. Medically, it does not matter who was born first. But in the family, in the culture, it's the entire difference. It matters completely. It's what it's all about. Because in many cultures, the firstborn gets all of the rights, all of the privileges, and the secondborn just gets support. Gets a supporting position in the family. So if you screw this up and you mislabel who was A and B, then you can doom this family to generation or multiple generations of Game of Thrones drama. So don't do that to the family. Get it right. If the first baby is born and the second baby doesn't come out for another 10 minutes, just transport, rapid transport. Something's going on. Now the complication is beyond the scope of this class. Just go. Okay. A premature birth is before 37 weeks, although I don't think they're going to test you on that. It's supposed to last 40 weeks, but it's only 37 weeks. What did I misspell? Ventilations? No. I guess it's just the dictionary. This PowerPoint dictionary. It doesn't have it, and that's fine too. Okay, never mind. The baby is really tiny. It's especially vulnerable to hypothermia, heat loss, so keeping the baby warm, very important. Many of their organs may be underdeveloped, so airway, breathing, circulation, absolutely a very important concern. And let the ER know ahead that this baby is born premature, because they're going to have that special equipment. Okay, so remember I said that throughout development the baby has been swallowing amniotic fluid full of flaked off skin, and it's going through the digestive system, and then finally it accumulates in the rectum as baby's first poop. It's called meconium. It's supposed to stay inside the baby until after birth, and then the act of being exposed to the elements stimulates baby's first poop. Anyway, that's the way it's supposed to go. But sometimes, if the baby is under a lot of stress, it will poop right into the amniotic sac before birth. But the problem is that, remember I said the fluid circulates around and then the baby swallows it and breathes it in? So it could be that the meconium is being breathed in by the baby. Here is what meconium looks like. It's this yellowish, dark red poop. It's baby's first poop. And if it gets into the lungs, it's an absolute disaster. So if you see this meconium staining, and it smells horrible, if you see this meconium staining on the newborn, then it's a good chance it got in the mouth. And so to reduce the amount that's going into the lungs, you want to suction the mouth vigorously. Okay, very rarely there is a genetic defect. A developmental defect. Some of it is genetic, some of it is caused by other things, where the spinal cord, the spine does not completely close around the spinal cord. And the last place that it was supposed to close up is here, down in the lumbar. But it does, sacrum, but it doesn't. Lumbar sacrum, it doesn't. And so what you're seeing, this bulge, is actually spinal cord. Very dangerous. No longer life-threatening. Well, it is life-threatening, but medical advancements, medical technology has advanced so far that once you get the baby into the hospital safely, they can take care of it. But you got to get him into the hospital safely. So what do you do if the newborn has this thing sticking out of their back? Saline moistened gauze, and then cover to protect against hypothermia. Okay, ectopic pregnancy. So we know by now that the embryo is supposed to implant somewhere in this triangle space, the uterus. If it implants anywhere else, it is ectopic, literally outside the place. Ectopic means outside the place. So outside where it's supposed to be. And the problem here is that only the endometrium of the uterus is built to receive the placenta, implant the placenta. If the placenta tries to grow in anywhere else, it's going to cause pain and bleeding. So, any woman of reproductive age who has abdominal pain must be evaluated for a possible pregnancy and an ectopic pregnancy. They do that with blood tests for pregnancy and a physical exam by the doctor. What do you do as an EMT? You ask them, is there any chance they might be pregnant? And if they say no chance at all, write it down. Don't be a lie detector. Don't be a psychologist. Just write down that you asked, and then write down what they said, and that's all. So at least the doctor can read it in case the patient becomes unconscious and is no longer available to ask questions. Spontaneous abortion is what the general public calls miscarriage. It is emotionally destroying. It emotionally destroys the family, the mother and the rest of the family, and you just need to stay professional and mature. Don't say anything stupid. I know as EMTs, healthcare providers, we feel like we're there to help people, we're there to help them feel better. We're supposed to be the experts. We should say something. Sometimes the best thing to say is nothing at all. Just document, bring all relevant material to the hospital. Do not let them go to the doctor. check airway, breathing, circulation. Premature birth, 30. Oh, they say 36 weeks because I accidentally said 37 weeks. Okay, so your textbook says 36 weeks. Let's go with 36 weeks. And then if they weigh under 5 pounds. Real risk of heat loss, hypothermia, even more than a regular term full-sized infant. Sometimes there is a looks like cheese on the skin, and that's what vernix caseosa literally means. It's Latin for cheese on the skin. Less hair because it hasn't had chance to grow that much. Post-term is the baby will just not leave. Baby is it's time for the baby to go, and they're just not leaving. So like they're staying in the body for mother for like a week or more. The baby is now so heavy and so big that vaginal birth is not an option really anymore. There has to be cesarean section. One of the most common causes of post-term or extra large baby is diabetes in the mom. Because what is diabetes but high levels of blood sugar? So if excess sugar is going to the baby, excess energy is going into the baby, and the baby, the developing fetus has like, oh my God, I'm so full of energy. What am I going to do with it? Well, I'm going to grow bigger. And so the baby gets bigger. Babies of diabetic mothers tend to be larger to the point where they no longer fit through the vagina. So if they try to have a vaginal birth and the tear of the perineum is a very real risk, doctors usually recommend cesarean. It's just too risky. And then newborn post-terms, remember they have the meconium building up in their rectum, and it's like, can you hold in your poop for a week? So eventually the baby is just going to have to let it out, but it's still in the mother, still in the amniotic sac. So the risk of aspirating meconium, very real risk there. Okay, so spontaneous abortion, trigger warning here. Maybe this came out. So what do? Stay professional, show compassion, don't say anything stupid, transport the mom. Say that the mother needs to be evaluated, that she is okay, and transport this as a biological item, really. Fetal demise, OB labor call, OB LAB call, you arrive, baby is born, but the baby is dead. What killed the baby? And I don't mean the baby was born and then died. I mean this means the baby died in the womb, and then finally the mother's body ejected the baby, and everybody thought it was birth. But the baby died a long time ago. So in fact, if you try to do CPR, you may be feeling a decaying body, foul odor of decay. The body is disintegrating. So what you need to do is stay professional, be compassionate, don't say anything stupid, transport the mother to the hospital for evaluation. You want to give the family closure, though. You want to give the family a chance of closure. So a pregnant woman, I said the heart rate is a little bit faster, so expect it to be 10 to 15 beats faster, which means if they could go from a heartbeat of 85 to 100, and it could be normal for them. It could be okay because it's because of the pregnancy. Because the mother has so much extra blood, she can lose more and still not show signs of hypotension. Okay, so other abdominal pain, vaginal bleeding, uh, where actually this slideshow doesn't go into the details of different kinds of vaginal medical problems, but the slideshow is saying that as an EMT you need to stay professional and show cultural sensitivity. Cultural sensitivity means not saying that your culture is better than theirs. It means not saying that your religion is better than theirs. Just respect your patient's culture and religion, respect their expectations, respect their requests, as long as it does not counter or interfere with your protocols. When in doubt, call for a supervisor if the cultural differences are causing an issue. That said, I have had experiences where, like for example, I had a female who is Muslim, and their culture is very strict that a strange male is not allowed to be present when the woman is disrobed. But because my patient was having heart conditions, she was suffering palpitations, and I said, I need to get these EKG stickers on you so we can monitor your heart. And she let me, no problem. And in fact, her brother, who was there, started to leave the room and announced that, okay, I will leave now. And I said, it's okay, you don't have to leave. And they both explained to me, no, the brother is not allowed to see her naked chest. But me, as the paramedic, I'm allowed. So maybe the cultures, when they came to New York City, transitioned and they understood, okay, these are healthcare providers. They are doing what they have to do to take care of me, so they are allowed. But don't assume that you will be or you won't be. Just ask. Just ask. Okay. So sometimes the young woman didn't even know she's pregnant because she never got sex ed. She doesn't know how these things work. She may be in denial. So be prepared for that kind of a story. Always protect their privacy. And now, for a teenager who is accompanied by your mother, there is a situation now. By law, the mother does not have a right to know. Like if you ask if the teenager is pregnant, if she is sexually active, like you ask these questions when the mother was not there, and then the mother later showed up and asked, why did she tell you? By law, you are not allowed to reveal that information. When it comes to issues of reproductive health and reproductive choices, the mother does not have a right to know. Now, most of the time, the daughter gives permission to tell the mother. Then you can say it because you have permission from the daughter. Or what I do is I tell the daughter, if you feel comfortable, you tell the mother. Don't get me in the middle of this. You tell your mom, because it's between you and your mom. But I am not allowed to tell your mom. I just put it that way. Signs of abuse. So just like with the abruptio placenta, which can be caused by trauma, and the trauma could be abuse. Oh, I forgot to say, I just remembered, this is slide 90. Let's go back to the difference between abruptio and previa, slide 21. So I said that placenta previa happens at the day of labor, and then abruptio placenta happens weeks before. That's one big difference. Another popularly known difference is that abruptio placenta is accompanied by abdominal pain, where placenta previa is not associated with pain. I'm not an OBGYN. I don't know what's the difference. Why don't they feel pain with placenta previa? It could be that the contractions of the uterus is causing so much pain that the placental pain is being drowned out. That's a possibility. But anyway, I don't know why for real. I just know that placenta previa is usually not associated with pain, at least in the textbooks and on exams, but abruptio placenta is associated with pain. Let's go back to slide 90 where I left off. So with abuse, the mother's body feeling threat. I'm not saying the mother's mind, I'm saying the mother's body feeling threat may decide to spontaneously abort. So if the baby is already viable, like ready to live on its own, then it's called a premature delivery. If the baby is not, if the fetus is not ready, if the fetus is not ready to live on its own, then it's spontaneous abortion. Premature delivery results in a low birth weight baby. Other traumas and abuse, like lacerations, can expose the mother to bleeding infection. Uterine rupture is when the muscles of the uterus rip away, depending on the kind of trauma she experienced. So when you're on scene size up, check the environment for scene safety to you, scene safety for the mother. When you're on scene, you are always aware of possible signs of abuse. And then if you have any questions, ask the patient in a private area. So I said that the mother is vulnerable to falling because she's out of balance and her joints are loosened. And then when she falls, that's a risk to the unborn fetus too, right? Right. Okay. Trauma, just like abuse, can cause all of those things I mentioned before. Oh, positioning of the seatbelt. Okay, when the seatbelt is pulled across the chest, that is the proper use of the seatbelt, and then the other half of the seatbelt goes across the lap. But because of the baby bump, sometimes pregnant women take the shoulder strap and put it behind their back. Sometimes the pregnant woman puts this shoulder strap and position it behind her back out of comfort, because it feels more comfortable that way. But that means the seatbelt is not functioning, not given a chance to function the way it was designed, and that can cause serious trauma to the abdominal area. Also, why do we have a shoulder strap? For a lot of things, but one of the reasons is so that if she's the driver, that the torso and head does not impact the steering column. By putting the shoulder strap behind her back, now she can impact the steering column. So be aware of that possibility. CPR. How do you do CPR on a pregnant woman? The same exact way. How do you do the Heimlich maneuver on a pregnant woman? Chest only. Remember hypotensive syndrome, supine hypertension. So you want to tilt her to her left and then do compressions. Embolism. An embolus is a clot that travels. And up to this point, you only learned about one kind of embolism, which is a clot that formed in the legs and traveled up through the heart to the lungs and caused a pulmonary embolism. But an embolism is any clot from any cause. Last week we did a lecture on face and neck trauma, and there I talked about air embolism, where the blood made contact with the air and it created clots. That can also cause pulmonary embolism. And now here's a third way to cause embolism, the amniotic fluid. After delivery, the blood vessels of the placenta were ripped away and the amniotic fluid is sloshing all over the place, there is a risk that the amniotic fluid, a few molecules of that, a few drops of that, made its way into the mother's circulation. Again, the blood makes contact with an unusual surface, the amniotic fluid, which up to this point there was a total separation, but now they are mixing. That can cause a clot, that can travel to the heart, that can cause a pulmonary embolism. So if postpartum, immediately after birth, the mother suddenly has difficulty breathing, her pulse ox suddenly starts crashing, that is a real possibility that she may be having a pulmonary embolism from amniotic embolism. Substance abuse, a reality unfortunately in our day, can affect the mother and the baby. Fetal alcohol syndrome is a set of signs and symptoms that the baby suffers because their mother took alcohol during development. Drug addiction causes all of these things, and remember, stimulants can cause placenta abruptio placenta stimulants. Vaginal bleeding, we already talked about that. Trauma to the genitalia, so a car accident, a bicycle accident, assault, rape. Evaluate, absorb the blood that's coming out. Speaking of rape, the instinct, last slide, the instinct of the woman, the victim, is to take a shower and throw away her clothes. But if you reach the victim in time, you should encourage them to not take a shower, not wash up, not throw away the clothes. What they should do instead is, of course, talk to the police, but come to the emergency room as they are, so that the emergency room can take samples of the assault, the perpetrator's DNA. And this has to be done in a certain way. What you're seeing on this picture is a rape kit, a rape sample collection kit. And there's a lot of papers here, and the purpose of all these papers, it's not just the bottles and bags, it's all this paperwork. All this paperwork exists to form a chain of custody. That is a crucial term. This is the key term. A chain of custody is a way to prove that the sample taken from the victim is the sample that is evaluated in the lab. And the results of that lab are the results that appear in a court of law. There is a continuous chain of confirmation that at no time was the sample or the report vulnerable to contamination or manipulation. Because if the chain of custody is broken at any step along the way, from the emergency room to the courier to the lab, then the lawyers for the defense can say, this did not come from my client. I'm sorry for what happened to the victim, but my client was not the perpetrator. You cannot prove that this sample came from my client because the chain of custody was broken. So, absolutely critical to make sure the perpetrator does not get away with this, that justice is served. The victim must go to the emergency room so that this emergency evidence kit can be collected, used properly, and a chain of custody can be established and is rock hard solid for the court of law. Right, it's been a long lecture. It's been a 3-hour lecture, I believe, and good thing I made a recording of it, because our scheduled lecture, there was an exam on top of this long lecture. So hopefully anything I didn't get to in the lecture is covered in this video for your own study, because now you have heard enough from me to do well on these relevant questions on the quizzes and tests. So good luck with that, and you'll see me on Monday.